Hi, I'm Vicky Brown and I'm an old age psychiatrist. I work in Bodmin in Cornwall, so we're the very southwestern tip of the UK. We look after people who've got challenging behaviour in dementia who can't be managed elsewhere, so that's what we do in my particular ward. Well, I didn't like psychiatry when I first did it. I found it dry and abstract, and I didn't bond with it at all. And it wasn't really until I met actual people, patients with psychiatric illness, that I started to really enjoy it. That was when I was working in A&E, and it made me change the course of my career. I was heading in a different direction before, but having met psychiatry and psychiatrists, I chose psychiatry. I felt like I'd found my tribe. I really like other psychiatrists. What I did was I joined a training programme up in Scotland, and then on that training programme there was a course for sitting the exam, so we went to that weekly, took the exam, and then at that point you had to submit a piece of research. That's no longer necessary. And I became what's called a specialist registrar, which is what used to be a senior registrar and is now a ST4 to 6. And then I became a consultant. So the path now, I suppose, is foundation doctor, then CT doctor, then ST, then consultant. I think it's not so much about what you know, but it's your personality, it's your attitude. It's a willingness to learn and a compassionate approach to people with dementia, because people with dementia have really quite specialist needs. They're slow, they can't always talk clearly, you might not understand what they say, they might not understand you, they have problems with continence, and that takes someone with a bit of patience and compassion. And then there's a lot to learn about the Mental Health Act, which you probably can't learn until you're doing it. So although you might learn the theory, we can teach you the practice. I think I like the people most. I like the patients. I like to work with the families. We can't cure dementia, but it's a lovely thing to help people when they're in extremis and you feel, you know, people have just reached the end of their tether and we can make a difference, so that's good. But also I work with lovely colleagues. The other old age psychiatrists are a good bunch of people, and then other people like social workers, nurses, they're all good people to work with. There are a few. One is we don't really have a cure for dementia, and we don't really know much about the treatment of functional illnesses like bipolar, anxiety, depression, mania in people who are older. But the flip side of that is that there's lots of opportunities for research, much more perhaps than in other areas. And then we also don't know much about the interface with physical illnesses like Parkinson's disease, motor neuron disease. There's so much more to learn. That's one challenge. Another is paperwork. Psychiatry has a lot of paperwork, lots of legal paperwork and lots of record keeping. So that is a nuisance if you don't like paperwork. The people who come to our ward have severe dementia. So generally speaking, they're managed by their GP at first, because GPs manage most mental illness in the UK. Then when the GP sort of runs out of options, they would refer them to the community mental health team or the memory assessment service, depending on whether they need a diagnosis or not. And then if the CMHT, that's the community mental health team, can't manage them, then they would refer them to us. The person would need to be detained to come to us. So we very rarely take people who aren't detained under the Mental Health Act. So they have to have reached quite a high bar of challenging behaviour, usually aggression. Sometimes it's fire setting, sometimes it's something more unusual like self-harm or starving themselves, that sort of thing. I would say go for it. It's a brilliant specialty. The people you know, the patients are older, so they've experienced a lot, and they've got really interesting stories. There's a lot of medicine involved, which is interesting if you like that sort of thing. There's lots of different ways in as well. So you could, as a foundation doctor, you could ask to have a specialist week. You could do a CT scheme. You could do it as part of a GP training scheme or as part of a broad-based scheme, or you could be a staff grade. There's lots of different ways in, and it's so you can come and taste without committing, and it's a really fun and enjoyable specialty to work in. Very person-centred, lots of opportunities in different directions. So. Thinking about my normal working day, I come in around 9 and sort of potter around checking up on anything that needs looking at, if anybody needs looking at overnight. Then at 9:30 we have a risk huddle where we go through what any new and emerging risks are, how we'll manage them. So it might be somebody who's become aggressive, or one patient is targeting another, that sort of thing. Then at 10 o'clock we have a board round where we go through the patients in much more detail, and that lasts about an hour. And then the rest of the day I'm doing jobs from the board round and also a lot of paperwork. So the Mental Health Act takes a lot of time, seeing the patients, speaking to their relatives, and in meetings really planning people's discharge, that sort of thing. That's mainly what I do. And also working with trainees, and I do a lot of supervision of people. So I supervise a prescribing pharmacist, a psychologist who's training to be an RC, which is a responsible clinician, which is somebody who can use the Mental Health Act, a nurse who is already an RC, trust grade doctor, and 2 junior doctors. So I spend a fair bit of time doing supervision. So we get CT 1 to 3 trainees come to my ward, and we have GP trainees. So we get people from all over, really. I've worked with people from all over the world. It's meant that I'm somebody who doesn't travel very much, but I feel like I've been well informed by my colleagues about what it's like in Cuba or Bhutan or Iran or Lithuania. You know, I've met people from all over the world. It's a real blessing, really. It's fantastic. So the difference really between being an inpatient psychiatrist and a community psychiatrist is that a community psychiatrist would spend most of their time either working quite closely with a clinical team who would comprise CPN, OT, and possibly a social worker. And they would mainly see people in their homes. There'd probably be some clinic work, but it's mainly domestic visits, home visits, which I thought was the best bit of old age psychiatry, really, getting to meet people in their natural environment. People are much more comfortable then. You get a much more realistic assessment of how they are compared to seeing them in a clinic. You see all their interesting furniture and meet their dogs and their families, so it's more interesting. They have less of the Mental Health Act work to deal with. They would detain somebody, then send them in, but they have more of different sorts of meetings called CPA meetings, care programme approach meetings. Thinking about what it's like as a trainee in psychiatry in the UK, it's probably quite different to other fields. So you have 1 hour dedicated every week to supervision, and that's divided into educational supervision and clinical supervision. But it's much more valued, I think, than it is in other specialties. So it's seen as sacred time that mustn't be interrupted, mustn't be broken, and you're expected to prepare a little for it, and you might talk about patients, you might talk about theories, you might talk about medications, all sorts of different things, but it's a real educational opportunity. Psychiatry probably works slightly different to other specialties in that it's less hierarchical. It's quite flat hierarchies. We're very much a team, and everybody's input is valued and everyone's speech has equal merit. And we also have to defend ourselves actually in ways that other doctors don't have to. So when I finish speaking to you, I'm going to go and write a tribunal report, which is to describe why a patient I'm looking after needs to be kept in hospital, and then I'm going to have to defend it in a couple of weeks at a tribunal with a judge, a doctor and a layperson. And that's interesting. It feels a bit challenging, but it makes you think quite systematically, because you're being cross-examined about your care of the patient. It makes you really focus on doing the right thing. So that's different to other specialties. As a trainee, you wouldn't be expected to do that, not as a CT1, but as a higher trainee, you can have a go at writing a tribunal report, and when you're close to consultant, you could probably present at a tribunal. So you're quite protected as a trainee in psychiatry in that you wouldn't be expected to go into any dangerous situations. You're given something called MAV training, well that's what we call it in Cornwall, which stands for Management of Aggression and Violence, and so you're taught how to break away and how to manage simple situations, and you're never put in a situation that you couldn't deal with, because we take it very seriously. You'd go and do home visits, but you generally do them with other people. You would do some clinics, probably with your consultant by your side. There's much more support than I hear people talking about in other specialties. Why choose psychiatry? So psychiatry, it's a misunderstood specialty, I think, and it still carries some stigma all around the world. And it would be such a shame to miss out on it, because it's a fantastic specialty to work in. It attracts people who are curious about how the brain works, who want a more holistic approach, and who enjoy having time to listen to patients' stories. So for example, our first appointments are usually an hour long, which must seem like such a luxury to people in general practice. And you get to see people more often possibly than other specialties, and you see people in really desperate extremes, and then you get to follow them up and see them getting better, well looked after, whether that's by themselves or people looking after them. You see people who are young, who have had terrible troubles, get better and able to really enjoy life and get jobs and get back into education. Also, another good thing about psychiatry is that you work with good teams of people. So you're working across housing, employment, social services, you have interactions with the police, which are really interesting. There's lots of different fields within psychiatry, so you can do old age psychiatry like me, but there's also child and adolescent, intellectual disability, general adult psychiatry, forensic psychiatry. People can lean more towards the very organic and chemical models, or people can be more psychodynamic and think more about relationships and social environment. There's also the opportunity to work with other people like neurologists, radiologists, other branches of medicine have big overlap with us. So I regularly see geriatricians and neurologists, for example, but people working in neonatal psychiatry would be interfacing with midwives and obs and gynae people. So it's a really varied, huge field, and if you like it, you really love it. And I say to trainees, make sure you choose the right job, because you're with it so much time. It's like choosing a spouse. It's like choosing your husband or wife, because you're spending as much time at work as you are with your family. So you want to have something you love. And psychiatry is something you can really love and get immersed in.